Dear colleagues, this is manual small incision cataract surgery. I prefer to call this surgery manual sutureless extracapsular cataract surgery, that is MSECS. The surgery has been started. Superior rectus bridle suture has been placed. The ocular surface has been thoroughly washed with betadine 5% lotion. Betadine 5% lotion has been applied in the preparation room for 3 to 4 minutes, and another application has been given just before starting the incision. The conjunctival peritomy has been done for about 7 mm and mild cautery is done. Mild wet field cautery. Care is taken not to cause any charring of the conjunctiva. Many colleagues can manage without wet field cautery, and that is probably a better technique. However, for the beginners, you can use mild wet field cautery. Now this is almost straight incision, and this incision is not very far from the limbus. The beginners will find it easier to place the incision near the limbus. Now I go into the clear cornea for a distance, and now a tunnel is prepared. Care is taken to maintain the same plane of dissection, so that the anterior wall of this tunnel, the anterior lip of this sclerocorneal tunnel, is of equal thickness all around, from one end to the other end. This is a 7 mm incision. For the beginners, I would recommend a 7 mm incision because that will be easier for them to deliver the nucleus. Now this is a side port. In this case, the cataract is almost mature, and I am going to use an air bubble to stain the anterior capsule so that capsulorhexis can be done very easily. The anterior capsule has been stained. Now the dye is washed out of the anterior chamber. Now viscoelastic substance is injected into the anterior chamber. I use 2% hydroxypropyl methyl cellulose. And in this case, I have planned to use a utrata forceps to do capsulorhexis. Through the side port, a 26 case bent needle cystitome is introduced. A cut is given on the anterior capsule and a flap is raised. And now the main incision is made partially on the right side for about 3 mm. Now I take the utrata forceps, tent the anterior lip of the incision and do a CCC. This pupil is mid-dilated, so I go along the border of the pupil to get an adequate sized rhexis. Viscoelastic substance is injected again, and the main incision is completed. Cut is given when I go forward. So whenever you make the main incision, cut when you move forward with the keratome. Now hydrodissection is done but the nucleus is not rotating nicely. Sometimes it is very easy. Sometimes the nucleus is rotating, but it is not coming out of the bag. This may be due to the mid-dilated people, because I think rhexis has been adequate. Now I'm using a Simcoe hook to prolapse the nucleus, but I found it cumbersome. So I asked for the Simcoe cannula. The Simcoe cannula, with the help of the Simcoe cannula, I'll aspirate the superficial cortex, and the Simcoe cannula will cause some more hydration, some more hydrodissection, and I'm trying to prolapse the nucleus with the help of this Simcoe cannula, and I have been able to do that. Now some colleagues can deliver the nucleus with the help of this Simcoe cannula itself. I tried that, but I was not successful. Iris was prolapsing from the left side of the main incision, so I stopped that. Now I am trying Visco expression. Visco expression is inject some viscoelastic substance in the anterior chamber and depress the posterior wall or posterior lip of the main incision, and the nucleus comes out of the anterior chamber. In this case I tried that, but I found that the nucleus got engaged in the wound, but it didn't come out. So at this stage I injected some more visco through the side port, and now I depressed the posterior lip again, and this time the nucleus came out. So the nucleus has been delivered, and now the cortical matter, epinucleus, cortex, everything has to be removed. Take the Simcoe cannula, flush some viscoelastic, flush some BSS into the anterior chamber, and a lot of cortex and epinucleus which was there came out just by flushing the anterior, flushing some fluid into the anterior chamber. Now see how beautifully most of the cortex has come out. Now little bit of cortex is there, and that can be easily removed with this Simcoe cannula. In India, Simcoe cannula was introduced by Dr. M.S. Ravindra, founder of Karthik Netralaya at Bangalore. This is a beautiful instrument, and without it we can't think of doing SICS. And now viscoelastic substance is injected, and a PMMA rigid lens is implanted in the capsular bag. PMMA lens is very good lens. PMMA lens, that is polymethyl methacrylate lens, remains clear throughout life. The lenses that I have used has been made by Appasamy Associates, and so far no lens has opacified, and there has been no glistening in these lenses. Like Acrisoft multi-piece and single-piece lenses develop micro vacuoles and glistenings over a period of time, and these PMMA lenses are very good remains clear. Probably the biggest benefit of SICS, though the wound is about 6 to 7 millimeter, the biggest advantage is this lens. Now cortical cleanup is done and viscoelastic substance is removed very thoroughly with the help of Simcoe cannula. First I flush BSS in the antechamber behind the lens, and then again some more BSS is taken and it is flushed into the antechamber. Dear colleagues, we must learn these surgeries very well because India, Bangladesh, Nepal, Burma, these countries have huge backlog of cataracts, people are poor, and phacoemulsification cannot be afforded by these patients. Many patients, millions of patients cannot afford phacoemulsification. For them, if we do the surgery with care, though the incision is large, it will heal nicely. See, there is no leakage of any fluid after forming the antechamber. There has been no leakage of fluid. Now the conjunctiva is advanced near the limbus by injecting subconjunctival dexamethasone and gentamicin. Superior bridal suture is cut, and as the eye is closed, as the speculum is removed, the conjunctiva gets opposed to the limbus. So this is sutureless extracapsular cataract surgery. Thank you very much for your attention.